regional webinar. Welcome to this regional webinar. It's a great pleasure to see all of you here. My name is Anjana Bhushan. I'm Technical Officer in WHO's Southeast Asia Regional Office and WHO's Western Pacific Regional Office and UNFPA's Asia and the Pacific Regional Office is the three offices are coordinating together to organize this workshop on the health sector response to violence against women, addressing violence against women in pre-service training. To begin with, it gives me great pleasure to invite Dr. Nina Raina, Director for Universal Health Coverage Family Health in WHO's Southeast Asia Regional Office, to deliver her welcome remarks to all of you. Over to you, Dr. Nina Raina.
Thank you very much, Anjana. I hope everyone can hear me.
Yes, we hear you well.
Okay. So I think there's some lag due to the, so I'll switch off my camera. Okay. So a very warm welcome to the regional webinar on health sector response to gender-based violence. Our colleagues from UNFPA, WHO, WIPRO, member states representing Asian Pacific region, distinguished participants. I'm delighted to welcome you all to this regional webinar, which is part of our events to mark the annual campaign, the 16 days of activism against gender-based violence. WHO's most recent estimates show that almost 1 in 3 women, which is not a surprise data for all of you, I think all of you know about it, that 1 in 3 women worldwide experience physical and or sexual violence in her lifetime, mostly from an intimate partner. The Southeast Asia region ranks second highest at around 33%. The very high prevalence of violence against women and its significant health impacts place it among today's priority public health issues. It is also a grievous violation of women's rights and girls' human rights. WHO brings attention to violence against women and girls as a priority public health and gender equality issue by building the evidence, developing guidelines, encouraging political accountability, and strengthening country capacity of health systems and providers. WHO has developed a range of evidence-informed resources, many with UN and other partners. WHO is partnering with UNFPA's Regional Office for Asia and Pacific to organize this webinar, and which focuses on recently released guidance on integrating violence against girls into pre- and in-service training curricula for health professionals. It also features information about action taken across countries in the region to integrate this guidance into curricula. The health sector is a critical part of a multi-sector strategy to prevent and respond to violence against women. And this is because women experiencing violence are more likely to use health services. Also, healthcare providers are often women's first point of professional contact. Third, all women are likely to seek health services at the same point in their lives. Finally, health systems have a mandate to address such violence through WHO's Global Plan of Action. It is my hope that this webinar will contribute to efforts to better enable the health sector to keep women and girls everywhere safe. Although this is 16 days of activism, but it should not be forgotten for the rest of the days. I feel that it's 365 days responsibility of each one of us to ensure that women are not subjected to violence at home or outside. Thank you very much. Over to you, Anjana.
Thank you very much, Dr. Raina. Now we move to Dr. Joanna Lima, Coordinator of the Health Enabling Societies Department in the WHO's Western Pacific Regional Office. I'll request Joanna to kindly make her opening remarks. Over to you, Joanna.
Thank you, Angela. Thank you. Also, just briefly, let me say that it's very lovely to meet you, albeit at a distance. I've heard so much about you here in Wipro. So lovely to see you. Dr. Nina, thank you so much for setting the tone. There's really very little I can add. So as Dr. Nina noted, the WHO's Global Plan for Action highlights the critical role that the health sector plays in responding to violence against women and girls, and also its elimination, and then to a different extent to also contribute towards prevention. It's true that we all heard this one in 3 women, and it's true that we all know it, but I mean, but let's say it again. Let's say it again. The global estimates show again, 1 in 3 women worldwide experience violence, gender-based violence, excuse me. But from our recent estimates from the Pacific, they paint a quite grim picture. So in our region, the proportion of women who have experienced this type of violence is the figures are almost double the global average. So to add to that quite grim picture of 1 of 3 in our region, we're talking about almost 2 out of 3. So without going into details, because I'm sure the other participants will go into a bit more into the epidemiology of it. So women aged between 15 and 49 years old in our region have experienced physical or sexual violence by an intimate partner. And here, again, the figures from our region are quite grim. So we have some countries where this could be ranged. In some countries, we'll have figures around 40%, estimated figures. We also have 47%, 52%, and in some other countries, 53%. So this is quite fair. I mean, in this audience, we don't even have to remind ourselves that this violence has enormous consequences to women's and girls' health and well-being. There's also a substantial human and economic cost for the survivors, for their families, and then the societies of their countries as a whole. We also know that this is not a given, right? It can be prevented, and the consequences can be mitigated. So whilst we know the health system alone, it's too much of an order, right, for the health system alone to adequately prevent, as it's a societal problem. So it's everyone's business, really, not just the health system. But in terms of the response, as Nina was also saying before, the response to gender-based violence, the health system here is obviously a natural system to cover it. Again, the systems, the determinants, the structural determinants lie in large part outside of the health system, but the health system is definitely the one thing we can focus on here. So as such, we have to ensure that the health sector does have a critical role in strengthening the health workers, often the first and only point of contact for these women, in strengthening these health workers' capacities to undertake selective screening, early identification, and so on, of women subjected to violence. So to do this, as was mentioned before, WHO has published and updated a global training curriculum with modules for training in service of healthcare providers. This is in 2021. And it has also, in 2022, developed a companion guide focusing on considerations for pre-service training to prepare medical, nursing, and midwifery students to facilitate a sustainable approach. The pre-service curriculum guide provides also guidance to help integrate and adapt sessions from the WHO curriculum to pre-service health worker education programs. And this provides guidance on the planning, developing, and implementation, and ensuring, again, this is what we want, right? That the future generations of the health workforce are equipped to provide comprehensive and survivor-informed care to those subjected to violence. The hope is that this will help us to enshrine care for women subjected to violence as a key health priority in this curriculum. So, I mean, I think we're preaching to the choir, right? So GBV and violence against women and girls is a shared responsibility. We all have a role to play, and we're hoping that these mechanisms will make this role, institutionalize it and make this whole approach a bit more sustainable in the long run. So I will stop here and revert to you. Thank you.
Thank you so much. It's now my pleasure to call on Ms. Catherine Kamkong, who's Regional Advisor for Sexual and Reproductive Health in UNFPA's Asia and the Pacific Regional Office, Catherine, please make your opening remarks now.
Thank you, Anjana, and good morning, respected colleagues from WHO, Sierra, Wipro, and across in the country offices also, to UNFPA colleagues across the region, and to all those from the Ministry of Health, those of you who are healthcare providers, to the midwifery associations, to nursing, midwifery, medical faculties, and to all our partners who are really working on the ground to provide quality services to survivors of violence. We really thank you for joining us today. When I was preparing also for the webinar, I was really reflecting on those horrible, shocking statistics that both my WHO colleagues referred to. And sometimes we get desensitized to these statistics of women dying, of women being injured. But we mustn't. We must still be shocked, and we must be compelled to act. When I was thinking of this, of these statistics about, 2 women are killed every hour and mostly by a partner, between 1 in every 4 women or 2 in every 4 women we just heard in the Pacific, or 1 in every 3. And then we also know that women with disabilities who experience much greater violence. Then I put myself in the health center, in the health facility, and I was imagining that 1 in 4 women that comes to see us for a family planning consult is likely to have experienced or be living in violence. 1 in 4 that are coming for an antenatal consult is likely to have experienced or be living in violence. 1 in every 4 of those women coming from a delivery to deliver her baby is likely to have experienced or be living in violence. This is a really shocking reality, and it makes us realize, though, as the other speaker said, how important you are as healthcare providers, as ministries of health, and as educators. You might be the difference between life and death, between risk and safety of a woman, of a mother, and her newborn who are living in violence. Now, let's imagine that those women who come to receive the services from a midwife, from a nurse or a doctor in all of our countries, imagine if they were treated with respect. Imagine if they were able to talk to a healthcare provider in a quiet and private space. Imagine they were listened to, really listened to. Imagine they were provided with the care and services that they need and have a right to. Imagine if all the clinics we worked in had emergency contraceptives to prevent unintended pregnancies from sexual violence. Imagine there are the required antibiotics there at our hands to prevent STIs. Imagine there's PEP kits to prevent her from contracting HIV from this sexual violence. Imagine if the healthcare provider coordinated well with the other service providers that the woman needs to ensure her safety and well-being. These things could change her life, and they could save her life. So our colleagues that are working on GBV, like my fabulous colleague Sujata here in UNFPA, and I think Anjana, you're also working on GBV in WHO, and many on the webinar, they're working, doing everything in their power to work with stakeholders to prevent and end these harmful social norms, practices, and gender-based violence. And it's a very long and a very hard road, and they need our support. Women need our support. So as we just reflected together, healthcare providers, we've said, are in this position where they're likely to see women and girls in our clinics, in our health centres, in our home visits, and in our hospitals. And those women are likely to have experienced violence. And that is why it's so critical we equip student midwives, student nurses, student doctors for this reality. We have to prepare them with the skills, the attitudes, the empathy and respect that they're going to need when they go out to work. So UNFPA, we're very proud to work with all of you on this huge task, and our very sincere thanks to WHO for this excellent collaboration on developing the guidance. We as UNFPA, we hope to build on our work with midwifery associations and midwifery educators across the 22 countries in Asia and 14 in the Pacific. And we also really hope to expand on our work incorporating disability inclusion in this health sector and pre-service education work, as we know that women with disabilities face a much higher risk of violence. So let us do all we can together to ensure women and girls receive the care they need to protect them from the consequences of violence. If we can grow respectful, caring, and empathetic midwives, nurses, and doctors in our pre-service programs, I think that we might stand a chance. Thank you, Anjana, and back to you now.
Thank you so much, Catherine, for those inspiring remarks. And with that, our webinar is off to a great start. I'd now like to hand you over to my colleague from UNFPA's Asia Pacific Regional Office, Megan Reinders, to introduce you to the health system response to violence against women and the in-service and pre-service curricula. Over to you, Megan.
Thank you very much. So what we're doing today is we already, of course, were just introduced by those who provided the opening remarks. But what we're doing is we're doing this webinar for all to sustainably strengthen the capacity of healthcare providers to respond to survivors of intimate partner violence and sexual violence and raise awareness of the pre-service curriculum, a companion guide, so that all healthcare providers can be ready to provide services to survivors of violence when they graduate. And if we can move on to the next slide, please. We will show a short video that shows the main point so that everyone is just at the same level of this, what role the health system has to play to respond to survivors of violence. I'm afraid we cannot hear the sound.
Experience violence at the hands of their husband or partner. That's over 800 million women worldwide. These women can feel trapped, afraid. Their lives are often restricted. Those who consider leaving often fear ending up penniless or losing their children. Over time, their confidence slips away, making a life without violence seem a distant memory. The abuse can lead to injuries, as well as serious physical and mental health problems, in some cases, even death. Many women contract sexually transmitted infections or have unwanted pregnancies, and when pregnant, have a greater risk of miscarriage or of having a premature or low birth weight baby. They can experience depression, anxiety, other mental health problems, or become addicted to drugs and alcohol. It can be hard to know who to trust or where to turn. But there is a place they can go. A visit to a local clinic is often one of the few opportunities women have to go out alone. And it's important for doctors and nurses to make sure this isn't a missed opportunity. When doctors, nurses, and midwives listen with compassion, survivors are more likely to share their story. When they ask the right questions, they can uncover what is really happening and challenge cultural attitudes that say it's okay for a husband to hit his wife. They can reassure women that it's not their fault and can work with women to help them stay safe. And where necessary, connect them with other services that can provide, for example, shelter, psychological support, legal services, and financial opportunities. More women can find their way to a life without violence when changes are implemented across healthcare and other systems. Changes such as private rooms for consultations, training that enables doctors and nurses to respond better to women's needs, and raising awareness of the harmful consequences of violence for women and children and how to prevent it. Making these changes helps foster a culture where violence is unacceptable and where women have the courage to speak out. Imagine if that could happen to each and every one of those 800 million women.
Thank you very much for sharing that. And we will continue the presentation. So through this, you could see what is the main role that the health system can really play in responding to violence against women, and why the health system has a role to play in this in the first place. So there are several guidelines and tools that can also help support healthcare providers, policymakers, and health managers in providing this response. So the ones that we really use the most are the two on the left here, and these are the clinical and policy guidelines responding to intimate partner violence and sexual violence against women, as well as the guidelines for responding to children and adolescents who have been sexually abused. So these are the global evidence-based guidelines that provide recommendations for the health system respond to gender-based violence. And several implementation tools have been developed to support the implementation of recommendations that we can see on the next slide. These implementation tools, yes, great. So with these implementation tools on the left, we can see the clinical handbook and the handbook for responding to child maltreatment. These are tools for healthcare providers that provide job aids to support. And on the second one we see here are job aids for health managers, so that they can guide healthcare providers and ensure also that the health system is ready to really provide the services for survivors. And the third one is really what we're focusing on in this webinar, is both the in-service curriculum as well as the pre-service companion guide behind it. And that's really what we're going to focus on after this slide and throughout the entire webinar. Then we also have the quality assurance tool that can help support how to really assure that the quality of the services is up to par. And there are also e-learning. So there's one that is used for the clinical management of rape and intimate partner violence for use in emergency settings, as well as a new one that was released last week for all healthcare providers. Now, the links for this you will find on the last slide in our webinar, so we will still be able to share that later. And now we will focus also on the recommendations that all of this is based on, what sort of training is needed based on the WHO recommendations. So firstly, training at pre-qualification level in first-line support for women who've experienced intimate partner violence and sexual assault should be given to healthcare practitioners, in particular doctors, nurses, and midwives. And healthcare practitioners should be able to offer care to women and they should receive in-service training that enables them to provide first-line support, teaches them appropriate skills, including when and how to ask about violence, the best way to respond to survivors, how to conduct forensic evidence collection where this is appropriate, and to address basic knowledge about violence against women, including laws that are relevant to survivors of IPV or intimate partner violence and sexual violence, knowledge of existing services that may offer support to those who have been subjected to intimate partner violence and sexual violence, to address the attitudes that might be inappropriate to provide services to survivors, for example, blaming survivors, so to avoid that. And also to address and reflect on healthcare providers' own experiences on violence, so that that would not influence the services they would be able to provide, and that they can also get services for their own experiences. Then also training for healthcare practitioners on intimate partner violence and sexual assault should include different aspects of the response to intimate partner violence and sexual assault, and training, again, on this should be integrated into the same program. So not to have intimate partner violence only in one or sexual assault only in one, but to really address both intimate partner violence and sexual assault into the same program, because there is some overlap between the two issues, and there might be limited resources available to integrate this, and this way they could both be there. We can move on to the next slide, please. So we can see here that this is the in-service training curriculum, and these are based on the clinical and policy guidelines, as well as the clinical handbook and the health systems manual that you saw earlier. And the aim is to provide healthcare providers with the knowledge and basic skills to implement the WHO recommendations in their clinical practice. And the target audience is for healthcare providers and health managers, as well as some policymakers, but it can also be used by others. And participants in or using this curriculum will learn how to provide women-centered clinical care, including identification for survivors of violence, providing first-line support through the LIVES approach, providing essential clinical care for survivors, and identifying also local support resources. And participants will learn to reflect on their own attitudes and understand survivors' experiences. And it emphasizes compassionate, empathetic provider-patient communication. If we move on to the next slide, please. Here we can see what the objectives are of this training curriculum. So there's to generate the general knowledge of violence against women as a public health problem, to really to have behaviors and also understand the values that contribute to safe and supportive service cultures, to have the clinical skills to respond to violence against women, and to have the knowledge of how to access resources and support for survivors, as well as for oneself, so that healthcare providers can also access the services for themselves. And on the left-hand side, we can see all the different modules and sessions that are included in the curriculum. So the first 13 modules here we can see are for healthcare providers, and 2 of those are also supplemental, so they are not necessarily for all participants, but as we have quite a few midwifery participants here as well, we can see that some of the supplemental ones are also relevant, for example, addressing family planning and HIV safer disclosure for women who were subjected to violence. And we can see how this is built up to really unpack all the manners in which a healthcare provider can respond to a survivor. So what skills they need, how to best do this, and all of this is competency-based. Now, if we could have a poll question, and I just want to check with technical colleagues whether they're able to include this, and otherwise I would like to ask everyone to answer this through the Q&A. Do all the participants, do you have any module on gender-based violence integrated in your medical, nursing, midwifery, or related program? So could you write in the Q&A, or could you write in the chat? Okay, I see some no's, and I do see some yes from others. Okay, so there are a few who do already have this, so that you do have a module or even a fully fledged program already integrated into your pre-service curriculum, and some do not. So we can also learn from each other later, and we will also have some panelists who can share the experiences that they have had to integrate this into their pre-service program. So thank you all for responding. We can move on to the next slide, please. So we can see that there is now the pre-service curriculum companion guide. So this document seeks to provide pre-service health training programs, such as in medical, nursing, and midwifery schools, with the knowledge and resources to better prepare their students to care for women subjected to violence. And the curriculum content on such care can ensure that the future generations of healthcare providers are equipped to provide empathetic, high-quality care to those who are subjected to or affected by violence. So although this guide is designed mostly for pre-service medical, nursing, and midwifery training programs, there are also several other programs that could benefit from the guide, such as those who are training in social work, pharmacy, physical therapy, occupational therapy, dentistry, and even for emergency medical technicians and paramedics. So the purpose is really to be as a companion guide to the in-service curriculum. So it is not in itself a curriculum for pre-service, but it provides guidance how to best integrate those modules from the in-service curriculum into a pre-service training. So it provides the pre-service health program with knowledge and resources to prepare students to care for survivors of violence, and how to best adapt and integrate the modules. So the target audience are curriculum developers, policy makers, educators, faculty, and clinical instructors. And it is using a competency-based approach that we can see on the next slide. We can see there the 8 different competencies that this is built on. So the first is to seek to mitigate, so that healthcare providers or pre-service healthcare providers who go through this can seek to mitigate the health consequences of violence against women, can demonstrate self-awareness of beliefs, assumptions, potential biases, and emotional responses that can affect interactions with women subject to violence, that those who participate can identify women experiencing violence through the signs and symptoms that suggest intimate partner violence, and also maintain a high index of suspicion. So when there might be violence occurring, that those who participate can adopt an approach to care and provide services that are non-blaming and non-judgmental and actually supportive of women subjected to violence. They communicate empathetically and sensitively and effectively with patients and survivors. They can demonstrate the skills to offer first-line support appropriate to their level of education for their profession and specialty. They know how to provide appropriate treatment and care to survivors of sexual assault, including rape and abuse, and that they can coordinate effectively with other services in caring for women subject to violence. If we can move on to the next slide, please. We can see here the 3 different steps that are used or that can be used to integrate modules into the pre-service curriculum. So the first is to plan, so to identify a champion and get institutional support, to conduct a needs assessment, and there is guidance available for that in the companion guide, to identify which of the competencies can be used and addressed in those modules, to develop a proposal, and also for that there's guidance in the companion guide, that there's a curriculum review committee available within the faculty that you're integrating this to review it and to plan for the next steps. Then the next step is to really develop the modules or to develop the curriculum. So to determine the structure, so whether this should be dedicated learning sessions, whether there's integration throughout a curriculum, or whether there are multiple dedicated sessions as well as integration into different modules. And we'll see the different approaches also when we go to our panelists later. Or it can also be through electives. Then what would need to be done is to select content and adapt it to the local context, to identify the different teaching strategies to be used, to prepare the facilitators and to define assessments, and lastly, to actually implement the curriculum content. So to pilot test, to create a safe space where healthcare providers or where also where the learning environment is, that is a safe space so that everyone can share in a safe manner. Then also to scale up and to evaluate and collect feedback to ensure that this is providing really that these meet the needs of the pre-service trainees. And if we move on to the next slide. So there's also some guidance in the companion guide that provides that already provides a selection that can help guide you for modules for preclinical pre-service integration. So for those who have not yet reached a clinical stage of their training, so that would be to integrate session 1 on understanding violence against women as public health problem, session 2 on understanding the survivor's experience and how practitioners' values and beliefs might affect the care that they provide, how to communicate best with survivors, and also how to provide first-line support, and especially the first 3 steps of that. And then for the next slide, we can see the selected core modules for the clinical pre-service integration. So when healthcare providers or when pre-service healthcare providers have reached the clinical phase of their training, that they can also focus on when and how to identify intimate partner violence, how to provide first-line support, to re-emphasize that, to really focus on that again, on the first part of first-line support as well as the second part of first-line support, and to provide the clinical care for those subjected to sexual assault, both for history taking and examination, as well as treatment and care. Now, do you have any questions about this companion guide and what we have provided so far? If you have any questions, please pop that into the Q&A. And at the moment, we don't see any. And if you do not have any questions, then, or if you don't have any at the moment, you can also ask them later and we can use that in the chat. You can put those in the Q&A section, and we have a moment dedicated to this later as well, so we can still continue with that. So Sujata, if I can hand over to you for the panel discussion, please.
Absolutely. Thank you so much, Megan, for walking us through quite a rich content in a very succinct way. So thank you for doing that. Now, colleagues, we move to the part of this webinar where we will be directly hearing from the practitioners from countries on their experience of applying these guidelines into their national curricula. And we are really honored to have speakers from Bhutan, from Papua New Guinea, from Samoa, and Timor Leste join us today. So let's turn to our esteemed presenters from the countries. And the first question that we can ask to my panelists today is really a reflection on the process that you've undertaken to integrate this content on gender-based violence prevention response into your pre-service curricula for nursing or midwifery or other medical professions in your countries. If you could reflect a bit on how you went about it, how did you determine which cadre of healthcare providers to prioritize, and what process did it involve in determining the pathways for this initiative? So if without any further ado, if I can quickly call upon our Bhutan team, Ms. Pasang Wangmo, Assistant Professor, and Ms. Sangay Choden Namgil, Senior Lecturer at the Faculty of Nursing and Public Health, Keser Gyalpo University of Medical Sciences. If I can kindly ask you to share your experience of the process in 2 minutes, please, and we'll project your slide next. Next slide, please.
I'm Pasang. Good morning, everyone, and happy to be the part of this regional webinar on health sector response towards violence against women, and to directly go to answer the question on process of how we went ahead with incorporating those component on violence against women in our curriculum. So firstly, after attending the workshop on violence against women in October 2022 in New Delhi. Then we returned back and we had a discussion with all the program leaders in our institute. So we asked them to visit, see into their modules, what are the components that are there and what are lacking in their module. And then depending on that, we have incorporated those into the curriculum after agreeing with the program leader and also those involved like curriculum officer, registrar, and also the subject experts we consulted, and then we incorporated those into our curriculum. And that is how we went about. And good thing was in some of the courses, it was timely in our institute to revise the curriculum because curriculum is revised every 5 years. But for other courses for which the curriculum revision wasn't timed, we had the flexibility in incorporating those violence against women topics because minor changes in the curriculum can be done at any time and major changes we do after every 5 years. Thank you so much. That is from my part.
Thank you very much. If I can turn to Ms. Jyoti Abraham, Senior Lecturer from School of Nursing at the University of Samoa. And if we can turn to the next slide. Yes, Ms. Abraham, if you're able to unmute and go ahead.
Thank you very much, Sujata, and thank you for WHO and UNFPA for reaching out to a small island country like Samoa to be part of this pre-service training information. So just to have a little bit of a background, in 2017, there were so many national issues such as domestic violence and intimate partner violence in Samoa. So according to a report in 2018, we heard that 6 out of 10 women experience intimate violence in Samoa. So that's one of the main reasons. And at that same time, there was a review for Bachelor of Nursing program. So it was timely to start adding more topics into the review. And therefore, we were able to add gender-based violence and domestic violence and violence against women and girls into the reproductive health courses in the Bachelor third-year nursing program. And in 2018, we started adding gender-based violence and into the reproductive health and childbearing courses for the postgraduate diploma midwifery program. However, that was not reflected in the curriculum because there was no review happening for a very long time. And then finally, we were lucky to have we were actually fortunate to involve UNFPA and Burnett Institute to conduct a review. And therefore, we conducted the midwifery curriculum review in 2022 and 23. And currently, we are into the new, implementing the new reviewed curriculum. And the WHO module, only sections were added. The reason for that was all the bachelor nursing students and midwifery nurses, new graduates were not doing a whole gender-based violence survivors. So they only look at identification and looking at the first line support, and then they refer them to the focal point. Each hospital in Samoa had focal points, so they are the ones who treat the gender-based violence and domestic violence cases. So therefore, the graduates were taught how to identify the cases, especially in antenatal care. The midwives will ask and do the history taking on how they do the identify gender-based violence cases and survivors, and they will actually refer them to the focal point for each hospitals. I think, thank you. That's all for that question.
Thank you so much, Ms. Jyoti, for that experience sharing, and we'll come back to you again to understand a little bit more of the granularity of your experience. But first, if I could kindly turn to you, Dr. Lydia Gomez, Dean of Faculty of Medicine and Health Sciences at the National University of Timor Leste. If you're able to unmute yourself, we'd love to hear your experience from your country. Over to you, Dr. Lydia. Dr. Lydia, we can see you, but we are unable to hear you. If you could kindly unmute. Sorry, Dr. Lydia, we could hear you for a fraction of a second and now we can't hear you anymore.
Hello?
Yes,
Can you
perfect.
hear
Please
me?
go ahead. Go ahead, please.
Good afternoon, everyone. My name is Lydia Gomez. I am a Dean of Faculty of Medicine and Health Science. Thank you very much, UNFPA, for giving opportunity to me to talk about the process of developing and implementing service curriculum of healthcare providers' response to gender-based violence in Timor Leste. In 2016, we began a collaboration between a National University of Timor-Leste and La Trobe University in Australia. We started by first doing research with health providers as well as women providers of violence to be able to understand more deeply about the culture and health system context. As the head of midwifery at the time, I wanted all midwives to be graduating with the skill to be able to care for vulnerable women. In fact, the International Confederation of Midwives, ICM, says responding to violence is a core competence for midwifery practice. We wanted to focus on pre-service education at university because it is a sustainable approach to training and awareness of on GBV for all new graduates into health workforce for years to come. When we were thinking about integrating GBV into the midwifery curricula, we first present and gain their support. As I mentioned before about research that we have done on violence against women together in the past gave us a good background knowledge and additional credibility. We gained a small grant to adapt, pilot, and evaluation the WHO curriculum on caring for women suggested to violence, which was being developed at the time. We formed a multi-sector working group to guide the adaptation process. This includes senior people with the two pilot university and the La Trobe University researchers, and a women advocacy organization, and the National Training Institute of the Minister of Health, National Training Institute and National Institute Training of the Minister of Health. The WHO curriculum was adapted as a whole, 16 modules, university subject within a second year of the midwifery degree. The WHO curriculum was it was done at the two main universities. They graduate the most midwife in Timor-Leste, the National University as well as private university. During the process, we adapt the WHO Memory Aid for first line support, lives, into acronym that makes sense and is memorable in the local language. We also adapt more content on responding to children and people with disability because violence against them is very common and we need to adapt to the country situation. We found it was important to develop additional Tetum language videos, role play activities, and guest speakers because people learn through many different ways, especially through seeing and doing. The subject was then pilot at the two main universities, UNTL and Crystal Institute. We did critical reflection on the content after its pilot round and amended the content to better fit the students and lecture need. Thank you for listening to my presentation.
Thank you, Dr. Lydia, and we'll come back to you with a few more questions on, your reflections and lessons learned, given the rich experience in Timor-Leste. I'm going to try one more time to reach out to Ms. Kathleen Alua to see if we can hear from you, the experience in Papua New Guinea. Ms. Kathleen, are you able to unmute yourself? We'll try one more time. Ms. Kathleen, we can see that you are unmuted. Go ahead, please. Go ahead, Kathleen.
Can you hear me?
Yes, perfect. Go ahead.
Awesome. Man, I've been having difficulty trying to get on these to join the regional webinar. Thank you so much, everyone. Let me briefly give a run through of what PNG is doing, Papua New Guinea is doing in terms of the national response to sexual and gender-based violence. The Health Sector Alliance, respond with the WHO Global Plan of Action on the response to sexual and gender-based violence. In line with that, the health sector has had a program in place within the public health division under the Family Health Service brands. So the gender health programming was birthed in 2013. So in 2013, we developed the National GBV strategy. The National GBV strategy is in line with, like I said earlier on, with the WHO Global Plan of Action in terms of response to the prevention and response to sexual and gender-based violence. So having the policy in place, with the technical support of WHO, we developed the in-service training manual. Also, we developed other clinical guidelines and that can support us in terms of training the in-service workforce. So within the timeline from 2013 to 14, 15, and 16, we realized that we need to train the health workforce. So in 2016, WHO, with the help of WHO and DFAT, we had to develop the curriculum on the pre-service curriculum. And during that time, it took us 9 years up till now. We've been pilot testing this curriculum to see into the PHAs, the provincial health authorities, to see that it can be tested. And we had an independent body that was the FHI 360. FHI 360 that to be there to be able to assess and validate the document after going through a robust check and balances within the health sector training division itself, especially the HR division. So the training unit has been there with us since the inception of that curriculum. And the curriculum is guided by the WHO clinical guideline and the other policy document. So in line with that, we developed that curriculum. And there's almost 13 modules in the curriculum. We also developed the facilitator's guide as well as the participants manual. And at this juncture, we have been ensuring that the TWG, the consultation process via the health sector gender-based violence technical working group, which is led by us, ensure that all our UN agencies, development partners, and international NGOs, implementing partners were part of the journey. We also pilot tested it and with the evaluation as well. So it is approved by the National Health Secretary for the MOH, for the general nursing schools, as well as the Community Health Workers School of Nursing, to be able to take that on board, to be able to institutionalize it into the training institutions within the country. So within that process, the training institutes need to request the transitional committee to be able to validate that document, review the document, to integrate it into the SGBV curriculum, which is under the social determinants of health. So we are at this process now.
Thank you.
Thank
Thank you,
you.
Ms. Kathleen. I'm so glad that you finally got your audio sorted and we could hear about your excellent work in Papua New Guinea, and we'll come back to you with a few more reflections and questions. Next, if we could move to a bit of an understanding about perhaps the challenges, right, that you faced in developing and implementing the pre-service curriculum. We know that you're at various different stages of this process, but if I could turn to our esteemed panelists one more time to request your reflection on your top level challenges that you faced and how you overcame them. And this will be a valuable learning, as you can imagine, for all of us who are joining and listening to you. So maybe if I can turn to you, Ms. Abraham, on the Samoa experience first in terms of the challenges that you face. Thank you.
Thank you, Sujata. For us, it was just starting. And in Samoa, we only recently, in 2021, we did the national response for Samoa, and we prepared Ministry of Health prepared a standard operating procedure document. So we were guiding on those standard operating procedure for most of the teaching and some of the WHO modules to work with the students. We also highly resourced from the UNHCR website as well to get some of the information to give to the students. However, our main challenge was collaboration between the Ministry of Health and the National University, because most of the responses were not we were not part of the stakeholder committee for preparing those. So therefore, we were not aware of a lot of stuff happening in the Ministry of Health, because NUS, National University, is a different semi-government entity and not, so the collaboration is a key, I would say, for pre-service education, because we are the ones who prepare the health workforce. Therefore, MOH needs to directly connect with the National University to include this information into the program. So how did we overcome this challenge? Actually, we looked for the training of trainers who are currently in the country, who have undergone this training, and we invite them to the National University to talk to our students and train them in that areas, and do as a 2-day workshop or 3-day workshop, so that they understand this what's happening in reality in the service. Yeah, thank you.
Thank you, Ms. Jyoti. Maybe I can turn to our Bhutan team if you have any reflections on the challenges that you've faced. Over to you, Ms. Sangay or Pasang.
Thank you so much once again. We do not have much challenge to share. However, in order to incorporate anything into the existing module, it was a challenge for us, because some part of the module or some not really important component inside the module has to be deleted in order to put those violence against women component into the module, and it turns out that the curriculum is becoming bulkier and bulkier, and each in a year many programs do come up, and each program has their own mandate, and they really want to have the sustainability over the years. And the one important thing about sustainability is they want to put everything into the curriculum. So that is a big challenge actually, but however, we have prioritized and put inside, and we have deleted some of not those really must know area, and then we have put in those must know area, good to know, and all those we have deleted, and we have put in those must know area into the module. Thank you.
That's a great strategy. Thank you so much. Can I turn to you, Dr. Lydia, if you have any reflections on challenges that you faced? Or Miss Kathleen, whoever wants to come in first.
As for PNG, we had a lot of challenges in terms of the funding support as well from our partners, and the consistency. It took us this long. I mean, how can you have a curriculum you have developed in 2016 and it's almost 2023? So the length of that period needed a lot of support from our partners. That was one of the challenges to get it going. And the second part of the challenge was that there are new emerging types of violence that is coming about, country specific and country context. In different countries, we face different emerging violence as well. So how to handle that and how to respond to that. How to sensitize our workforce. So those were some of the things that kept us thinking along the way in terms of the completion of that curriculum, as well as we have a WHO curriculum, which is the 2021, the latest policy that is out already. And how do you get that and contextualize it into the country specific content? So those are the challenges that's coming about, but we are making sure that we have the content itself, that it speaks to what we want, so that those new guidelines can guide us in the next content, in the next review. So we've downsized a lot of those informations as well, to make sure that we get the content itself, so that it is right for the audience at the School of Nursing. So those are the challenges we've been encountering, and also the violence against children component as well. We had to make a special consideration of children in that in the module, in the curriculum. So those are some challenges we have faced in the country.
Thank you so much, Ms. Kathleen. That I think is relatable to many of us who are listening to you. Dr. Lydia, would you like to reflect upon this?
Yes, sure. Thank you. The challenges that we face here in Timor Leste, gender-based violence program in the health sector is new, and not many lecturers being trained on how to teach the gender-based violence curriculum. So how to overcome the challenge, we conduct 2 rounds of the lecture training in 2019 and 2020. But our lecture need more support across the 6 universities. Thank you.
Thank you very much, Dr. Lydia. I know the time is running fast, so I do, but I do want to make the most of the experiences that you have. So maybe one final question from our side, linked to the challenges. If you have any key lessons learned that you'd like to share with us, colleagues, in particular, as you can see in the chat, there's a lot of conversation going on about, building on this and how we can learn from each other. So those of us who are joining this webinar and are interested in pursuing this, do you have any words of wisdom, any advice that you'd give from your experience in undertaking this initiative? Could I turn to maybe the Bhutan team to start off with this? Ms. Pasang or Ms. Sange? Yes, go ahead.
Yeah, thank you, Sujata. I think we can all understand when it comes to this question about the lessons learned, although there are so many similarities in the world when it comes to violence against women, one thing that we can learn from, one thing that we, Bhutan team, learned from the inclusion perspective, the curriculum inclusion perspective, is that the importance of contextualizing the knowledge and skills we teach our health workers, the health students, particularly in the light of the fact that they will be interfering on different levels. I think it's also important to consider one's own cultural elements, like gender equality, hierarchy system, and also we have had a study done by the National Commission for Women and Children, which covers the population in both rural and urban. We still have a fair section of women population who feels that it is acceptable for them to be subjected to violence by their intimate partners. So considering all of that, I think we have to make considerable changes. Another thing that I would really emphasize on is the trustworthy of data. As I was just reflecting to the survey that we've had, first of a kind in the country, I think the different manifestations of violence against women in one's own culture, gender-based violence and other crucial components relating to violence. Another thing that we can also dive into is the identifiable strengths in individuals and communities, I think, to prevent violence against women. The treatment, the prevention strategies, all based on one's own community resources. So these are some things that I would say that are the lessons that we've learned after we implemented, the modules. Thank you, Sujata.
Thank you so much. Thank you. Could I turn to you, Dr. Lydia, if you have any experiences from your end and any advice for those who are starting this process?
Okay. Our lesson learned local learn resource. We develop enhanced students' learn experience, and we believe this contribute to successful learn outcome. The first line support aid in Tetum language, our local language. The high record of the Tetum adapt version of life, this line support how to importance of memory aid in our local language. Long-term collaboration. This has been a big learn process for all of us, which was made possible by the long-term collaboration and support for each other. And leadership within the university
Dr. Lydia, we're losing you.
The curriculum has now been incorporated as a core subject university. The GBV curriculum has now been incorporated as a core subject within the midwifery program at both the pilot university in Timor Leste, because there was space for leadership within our midwifery department, and this work has supported high levels. Support for others, we have already trained university lecture in our own and the other university over 2 rounds of training. And we are currently working with Minister of Health and UNFPA to develop a national service curriculum and mentor implementation with district. And then is an ongoing process. It takes time and dedicate effort. We hope to provide more mentor training and follow-up support to lecture and national trainers, because people need close extent support over time.
Thank you, Dr. Lydia. I'm so sorry of the audio connectivity issues that we are facing, but I think we got a crux of what you're saying, and we'll also get that covered when we send out the
Timor
notes.
Leste advocacy work with the Commonwealth, existing collaboration and cross-institutional relationship, including support from the Latour University and WHO Geneva. Advocate embedded in leadership position within their institution. Extended timelines in work to the few years and is ongoing. Flexible budget so we could adapt and respond as needed. Patience and commitment by all our team and trust in each other the whole way through. Now that responding to GBV is included in national midwifery curriculum in Timor-Leste, we need to work hard to influence the medical and nursing school during their next curriculum accreditation process. We are currently working with the Minister of Health and UNFPA to develop national in-service curriculum. The mentoring and follow-up support we provide after training. In the critical next step, we need to focus on for both pre-service and in-service so that health staff can implement the new health service. Thank you.
Thank you, Dr. Lydia, and sorry about the connectivity issues. I'm going to quickly turn to you, Ms. Jyoti, if you have any final reflections with regards to the lessons learned and any kind of advice for those who are starting in this process.
Yeah, thank you, Sujata. Again, we also having power issues here. The video is kept disconnecting. Yeah, the main lessons we learned are that our students cannot do much because we are depending on focal point to be carrying out these things. And also in Samoa, it's kind of, so again, as the Bhutan team said, we also need to consider the context, and sometimes the cultural issues are also there. Talking about sexual violence and gender violence and intimate partner violence directly to the clients are also an issue and taboo. So therefore, sometimes identifying this will be quite late for some of the students. So we need to really consider in the context before we actually teach them what content we are going to teach, depending on the looking at the module. And what we learned was the students giving the snapshot of what gender-based violence, how to identify, first line support, looking at the acronym lives. These things are much important for these graduates to understand so that they can refer to the direct services they need. And some of the services we have are the mental health services, also the victim support group in Samoa. So therefore, this referral is really working well. And that, so I would suggest that look at the context and how things work locally rather than looking at an international way of doing things. So adapt to, take whatever is needed and adapt to the context. Yes, I think
Brilliant.
that's what
I
would like to say. Yeah, thank
you. Thank you. And that was very heartfelt. Thank you. Ms. Kathleen, any final words from you?
Thank you. I would agree with Samoa for that. Looking at the country's local context really works. So adapting and contextualizing it in that setting works for us here as well in PNG. I want to make a statement here that with the support from WHO and our UN partners and other partners, we have gained a lot of success stories. We just had the country's summit yesterday. We had a panel discussion about the health sector's response and to sexual and gender-based violence, and the only institution that mothers and children and the survivors come to is a health facility, and the most reliable one. So the curriculum will go a long way, and the support from our partners is very important. There is something us to take note of. Once we have the document in place, it is always good for the partners to consult what the government has in place already, rather than coming in and trying to develop something that can work parallel or duplicate what is there already. So that is one thing which we need to know, so that we do not have those kind of conflicting situations here, because countries have their own, way of doing things and operating and doing their business. So I would like to appeal to the partners to see that whatever the government has done, please let's support, and rather than duplicating or doing parallel kind of support. So thank you for giving me this time to talk.
Thank you, Ms. Kathleen, and it's a really valid call to action, especially as we are having this webinar during the 16 days of activism, and it really calls upon all of us to join forces, build upon what we have, avoid duplication. There's very limited resource to work towards addressing gender-based violence in any way, so let's maximize our resources, our energies, our technical capacities in that way. So with that, I bring this panel discussion to a close, and I hand over to my colleague Judy Fong from WHO Wipro to moderate the Q&A. Thank you, and over to you, Judy.
Thank you, Sujata, and thanks so much for having me here today. I'm very glad to be with you all and hear about all of these very rich and insightful experiences from all of our government stakeholders today and partners in country. I just want to open if there are any questions. I mean, for the moment, I think one of the key questions that have come out in the discussions is looking at what do we do in the case that there isn't a specific specialized training faculty to teach on gender-based violence. And maybe here I will actually turn to some of my colleagues, Sujata, Megan, if you want to come in here, and then maybe we can also turn to our country colleagues that are with us as well. Megan and Jana, did you want to come in here? So just some of our colleagues in the chat have asked us about in the case that they don't have some specialized faculties at the universities, who would be able to step in to support them there? Is there a way for them to mobilize resources? Would it be UNFPA and WHO's role? Or are there other stakeholders in country that they can also request support on?
If I could come in on that question, Judy, thank you for that question, and thank you to colleagues who shared that concern in the chat. I just wanted to share with everybody that last year we collaborated, Sujata and our office, so Asia Pacific UNFPA Regional Office and the Southeast Asia Regional Office of WHO to conduct a regional training of trainers workshop. There has also been a global training of trainers, and we were able to draw on the global pool of trainers from this region as co-facilitators for that workshop just over a year ago. And as a result of that workshop, we now have a pool of trained experts in the region that could be resource people to countries where local expertise is lacking. And they would supplement, of course, our technical support that we provide through our country offices and our regional offices in both the agencies. So we do have that pool, and colleagues should feel free to connect with myself or Sujata afterwards, and we can connect you with those experts, several of whom actually are on this call today. Over for now.
Thank you so much. And just to comment on that, there's also quite a bit of movement building up in terms of working with the various institutions, the midwifery academies and the nursing institutions, etc. And so I think there are also opportunities in terms of engaging at that level. So we look forward to engaging at the country level to support that, building on, as Anjana mentioned, the pool of trainers and resource persons that we are investing in, and we'll continue to invest in that. But but also to really work with the governments at the country level to ensure that the new resources and the guidance that's coming up are incorporated. I have my colleague Catherine joining, and I just wanted to ask you, Catherine, to reflect a little bit on the work with the midwifery associations in terms of building that capacity as well.
Sure, Sujata, thank you. It was really wonderful to listen to all the colleagues' contributions today. And I think, I mean, in APRO, we've partnered with the Burnett Institute over the last many years, and we've been doing work with midwifery faculty from all of the different countries in Asia and in the Pacific. So I really, when I was listening to this, I was thinking about how we could expand and continue that work and really have some reflection on this guidance and how we can support the countries with incorporating this into their midwifery curricula. Sometimes I really hear the issue that one of the speakers raised about this challenge of time. You know, we have a very limited time in a curriculum for different content, and it's true that many people come with different, you know, things that they want incorporated, but I feel like there's lots of ways that we can do this. It doesn't necessarily need to be standalone module. We can look at incorporation throughout the curriculum. And yeah, so, but we'll really look forward in the coming years, next year especially, to see what we could do with the midwifery faculties and the midwifery associations to, you know, to really support the rollout and implementation of this. Thanks, Sujata.
Thank you, Sujata, and thank you, Catherine, as well. Maybe just not seeing a lot of questions coming to the chat. I think there's a lot of sparked interest amongst all the different colleagues, and I see that a lot of the other countries are currently sharing their experiences, which is great and very appreciative. So I might actually turn back to our country panelists that are with us today, and maybe if they want to come back and share with us how their pre-service and the in-service training curriculums have actually complemented each other. I think as we had gone through before, everyone's currently in the different stages. We see that some of them are quite a lot more advanced in terms of where they are regarding the pre-service, and of course in terms of the in-service. So maybe I just turn to Timor Leste, if you want to kindly share your experience about how these trainings have complemented each other, and what work you've been doing here to ensure that the curriculum has been integrated either formally or informally. Thank you. Sorry, Dr. Lydia, are you still with us? To our other colleagues from Bhutan or Papua New Guinea, would you like to share with us? Or perhaps I see Jyoti is still with us. Would you like to share with us some of the experiences in regards to the pre-service and in-service curriculum?
Yeah, thank you for the opportunity. For us, pre-service, currently, as I said before, the midwifery curriculum has been reviewed and all the GPV modules have been inserted into the curriculum. So therefore, we need to develop on including those WHO module into the curriculum. So that's a big work we have ahead. And for in-service, they're actually doing the training already. And I would say that continuous monitoring and as I said before, the new graduates are not really involved in the GPV identification. They're just involved in identification, but they are not treating them. It's usually the focal point. So therefore, more in-service training is important to continue that update, and also to look at ongoing training needs to be there in service. Thank you.
Thank you, Jyoti. Dr. Lydia, Kathleen, would you like to add anything to our colleagues' comments?
Thank you. How did our pre-service and in-service training complement each other? What we developed was the first thing we developed was the in-service training, because we need to sensitize our workforce, those who are already out there providing clinical services to our survivors. And they just need to know the know-how. So with the WHO guidelines in terms of responding to violence against women and girls, and the violence against children, we decided to develop the pre-service. So we've been running the pre-service throughout the country. And we needed the lecturers, we needed the teachers, we needed the schools, the health institutions to be able to train rather than us training. So we've been also training as a TOT, trainers of trainers, a pool of trainers that can be able to train the other workforce within their own establishment or their own provinces. So that has been going on until we decided to develop the in-service training. So we had to get what is relevant from the pre-service package to be able to contextualize it into the in-service training package with the support of all the other documents, evidence-based documents from WHO and UNFPA. So those two have been, those have complemented this new curriculum which we have developed, and we have integrated it formally, and it has gone through a robust check through our societal members, especially the ONG Society and the Pediatric Society. Also the National Department of Health Advisory Body and the training division, so that it can be able to sit well within the government training institution and also our church-run training institution as well. So yes, they both complement each other. Thank you.
Many of you have shared your experiences from other places, and I thought that I would just wrap up with a couple of words. One, the webinar recording and the slides will be shared with all of you afterwards. And two, the action points. So from our discussions, I've come up with the following action points. For all of you, the participants from the member states and other stakeholders, we hope that if this webinar has served its purpose, that after this webinar, you will review the available guidance to guide your scale-up of efforts to prevent and respond to violence against women and girls, both in terms of policies and actions. Second, we hope that you will gather stakeholders from the country to discuss and plan how you would like to integrate this issue into pre- and in-service curricula. And I note that beyond the panelists, several countries are already in this process and are not starting from scratch. Of course, you are most welcome always to reach out to WHO and UNFPA at the country and regional office level for any technical support or advice that you need. On our part, we note two very important action points to follow up from this webinar. The first, as I said, we will be sharing the webinar recording and slides with all of you. And as I close, we will be showing you the final slide, which is a list of our resources. And we will also contact our country offices to see and identify whether any immediate requests for technical support have come from this webinar. But more broadly, we'll continue our efforts around policy dialogue, national capacity building, and technical support in our countries to strengthen efforts to prevent and respond to violence against women. Thank you so much once again. And with this, we close the webinar. And I'd like Kunnanut to share as we close the final slide on technical resources.